So I think what we can conclude from this session on BCMA redirecting, BCMA-specific T-cell redirecting antibodies is that they are very effective. We have the whole story started, in fact, with the AMG 420 BiTE. So BiTEs are very small molecules that bind with one part to the tumor cell and with the other part to the T-cell, and thereby the tumor cell and the T-cell are brought into each other's proximity, and then the T-cell can eliminate the myeloma cell. And the AMG 420 BiTE is very small, is excreted by the kidney, so you need to give it via continuous intravenous infusion, which is more cumbersome for the patient because often you need a central line. It's also more inconvenient for the caregivers, but nevertheless, the AMG 420 BiTE provided the evidence that BCMA-specific T-cell redirecting agents are very effective, because response was like 70 to 80% at the highest dose level, at the MTD, the maximum tolerated dose, and of course a 70 to 80% response in heavily pretreated bortezomib, lenalidomide, carfilzomib, pomalidomide, and CD38 exposed patients is very good. But because of its inconvenience, new developments took place, and now we are mostly using IgG-like bispecific antibodies, which have a larger size, are therefore not excreted by the kidney, and can be administered either once weekly, and some of those IgG-like bispecific antibodies also every 3 weeks. So this is much more convenient for the patients, which can come to the hospital and come back 1 week or 2 weeks or 3 weeks or sometimes even a month later. And there are several of these IgG-like bispecific antibodies. We have AMG 701, we have Teclistamab, we have Elranatamab, we have a Regeneron compound, and also a compound from TeneoBio. And overall, these IgG-like bispecific antibodies are very effective, 60–70% overall response rate, and the main toxicity is cytokine release syndrome, which typically occurs early during step-up dosing or the first full dose, but can be managed well with either steroids, or I prefer to give these patients with CRS a little bit of tocilizumab, and then everything settles down. Other toxicities are hematologic toxicities, and in 2 studies, the AMG 420 study and in the study with Elranatamab, there were also some patients with neuropathy. So we have to see whether this is because of typical combinations, whether it's specific for certain compounds. So we have to learn more about this rare side effect. So, for example, with the Elranatamab compound, it was the neuropathy was seen in the POM combination, and we know, of course, that POM can induce neuropathy, especially in patients that have already pre-existing neuropathy. So very effective, very well tolerated, those BCMA targeting agents, but we have to do better. So ongoing studies are looking at combinations with IMiDs, combinations with CD38 antibodies to deepen response and to improve response duration. We are also looking at the combination of 2 different antibodies, for example, Teclistamab and another GPRC5D targeting antibody, to target 2 myeloma-associated antigens to prevent antigen escape, because we know that when you target one antigen, the relapsing tumor, the tumor cells that outgrow, are typically may lose the expression of the targeted antigen. And indeed, not only for BCMA CAR T-cells, but also for BCMA bispecifics, it has now been described that BCMA loss, biallelic BCMA loss, is one of the causes of relapse. So combination of bispecifics or dual antigen targeting with CAR T-cells may be the solution to prevent this. When you talk about the bispecifics, I also had a story about Talquetamab, and this is also a very promising bispecific antibody, but Talquetamab not only binds to CD3, but now targets GPRC5D as the myeloma-associated antigen. So this is a different myeloma target, and can therefore be used effectively after prior treatment with the BCMA antibody. And as mentioned, maybe also be combined effectively to improve duration of response. Talquetamab is also a very effective bispecific antibody that can be given subcutaneously once every week, and also other administration schedules are being evaluated, like every 2-week administration, which is more friendly for the patients. And Talquetamab induces a very promising response rate of 60 to 70% in triple-class exposed patients, which is, of course, again, like with the bispecifics targeting BCMA, very promising. Well, speaks of the power of T-cell redirection in multiple myeloma. Main toxicities are, again, cytokine release syndrome. We see hematologic toxicities, and specific for targeting GPRC5D with Talquetamab is also the occurrence of skin-related adverse events. And some patients also have nail disorders, so the nails can drop off, and some patients have loss of taste. Typically, these specific side effects can be managed with topical steroids or dexamethasone mouthwash, or sometimes you have to increase the dosing interval. So also a very effective and well-tolerated bispecific antibody, Talquetamab. Many studies are planned with Talquetamab and also with the other BCMA targeting bispecific antibodies. And to be complete, I think it's also good to mention that Cevostamab, that is also targeting another myeloma-associated antigen, is also well tolerated and effective in this set of heavily pretreated myeloma patients. And Cevostamab targets FcRH5, which is highly expressed on the myeloma cell and much lower on B cells, and except those cells, not on other cells in the human body, which is important when it comes to side effects. So I think overall that bispecific antibodies are very effective, very competing with CAR T-cell therapy. And there were many stories at this meeting about CAR T-cells, about ide-cel, about cilta-cel, also very effective and inducing very durable responses. Big advantage of CAR T-cells, of course, is the one infusion, the single infusion, and then hopefully a very durable response. While the bispecifics need to be given until progression. And when you have one shot and then nothing, can also be very attractive for the patient. Big advantage of the bispecifics is that they are off-the-shelf available, so can be directly given to patients that are needing treatment and cannot wait for a couple of weeks for CAR T-cell manufacturing because they have aggressive disease, rapidly increasing tumor load, and become symptomatic if you wait too long.